Okay. So now moving on to hormone replacement therapy. So before we go on to hormone replacement therapy, I think it's quite important to understand what menopause is. Um, so menopause is basically defined as primary cessation of menstruation. It is caused by loss of follicular activity. Menopause is clinically diagnosed in primary care when the woman has not had a period for a year, right? So menopause symptoms are very common. It affects mostly 75% of women, and they can typically last from 2 to 7 years, generally 2 to 5 years, but may resolve quicker. And the duration and severity is also variable. Some cases may start years after the onset of menopause. So, management of menopause is split into categories. Yeah, before we go on to that, I would want to talk about um, the functions of estrogen. So, what is basically menopause? In menopause, what are we losing? We are losing our reproductive hormones, isn't it? So, reproductive hormones being estrogen and progesterone. So, progesterone mainly has a role of maintaining the endometrial lining or thinning it out, but estrogen has many roles, not just reproductive, not just stimulating the follicle and making ovulation occur, but also it plays multiple roles in our body otherwise as well. Um, does someone know about other roles of ultrasound? Oh, can people hear me? Because on the chat, I think it's
I think
frozen.
I think most of us are okay. If you
Okay,
are having some technical issues, please let us know. Slash a good fix is to leave the chat and then come back in, or leave the call and then come back in.
okay.
Sorry, what was your question, Ikra?
Yeah, but I just asked if people know what the functions of estrogen are, apart from the reproductive ones. I know we're a bit short on time, so I will try and make it quick, but this is important. Yes, bone mineral density, very good. Okay, I will let everyone know, but these are important, so listen up, okay? So basically, oh, Lindsay is writing something. Fine. Yes, yeah, you can say. So the functions of estrogen are skin hydration, so maintenance of hydration of the skin. So you guys must have noticed that anyone who's gone through menopause, their skin starts to dry out more, and they need more moisturizers and creams to maintain that, and they also start having wrinkles. So um, the hydration and the tightness of our skin is also controlled by estrogen. It helps to maintain the mood. So people who are going through menopause are very, I would say they get very cranky. For some of our patients, they feel like they are very always on edge, and they're always, usually they were very chill, and now they're quite irritable all the time. Um, and then it also helps to maintain the bone density, as Lindsay said. And it also, one of the main functions of estrogen is thermoregulation too. So apart from the reproductive functions, estrogen has many functions: thermoregulation, maintaining bone density, maintaining mood, and skin hydration. um, so if you take out estrogen, then a person will not be able to regulate their temperature, so that can cause hot flushes, right? And night sweats, um, because it maintains the mood. The patients can have very can they can be very irritable, depressed. They can have dry skin, not just on their face and hands and exposed parts, but also around the vaginal area. It can be very dry. um, and they are very prone to having fractures if they fall postmenopausal. Uh, if someone postmenopausal old lady, not old, sorry, just postmenopausal lady has a fall, she is more prone to having a fracture than someone, uh, some male person in the same age. So now talking about menopause. So the climacteric phase is defined as the period of transition from women's reproductive to non-reproductive life and extends from 40 to 65 years of age. So anyone can have a menopause between 40 to 65. It is divided into perimenopause and postmenopause. So perimenopause is while she's having all the symptoms and she's still experiencing periods. So symptoms are caused by reduced levels of hormone. We've already discussed that. What happens is the length of the menstrual cycle and the frequency of menstrual cycle changes. Patients can have dysfunctional uterine bleeds, so bleeding can occur in between cycles as well. We've already discussed that vasomotor symptoms like having night sweats and hot flushes are very common. This affects about 80% of women. So this is one of the main symptoms that distresses out patients. Then vaginal dryness is also the, the very common. It occurs in about 35% of patients. And patient because the tightness of muscles is also controlled by estrogen. The our bladder muscles also become a bit loose, which is why so we women experience that they need to go to empty their bladder quite often. Psychological, we've already discussed. 10% of women suffer from anxiety and depression because of that, and osteoporosis. Um, Now, management can be done with three things. So, lifestyle modifications, and then we can give some management without the HRT, and then HRT can also be used. HRT being a hormone replacement therapy. So, when we talk about lifestyle modification, a few symptoms can be dealt with lifestyle modifications like regular exercise, weight loss, and reducing stress can improve hot flushes. They can improve mood and cognitive symptoms as well. Um, and um, yeah, if we help them maintain a good sleep hygiene, sleep can improve, leading to improvement in cognitive symptoms as well. What we mean by sleep hygiene is that having no caffeine before bed, no toothbrush, having a proper sleep routine, and a good sleep and sound, and not to eat a couple of hours before bed, and having a routine, as I said. Then comes how to manage. So this is not definitive because it's just lifestyle modification. It does work for some people, but it might not work for all of them. So with non-HRT but with medication, we can SSRIs basically. They are they've see we've seen that they're very helpful in improving the vasomotor symptoms, so the hot flushes and the night sweats. They're very helpful in those. Common SSRIs being fluoxetine, citalopram, venlafaxine. Psychological symptoms can be improved by joining self-help groups. We can also refer them to have CBTs or antidepressants as well. And for vaginal dryness, we can give them vaginal lubricants or moisturizers. We can also offer them estrogen gels or creams, but that will be hormonal, not non-hormonal. Um, yeah. So, does anyone have any questions up till now?
I think you can continue.
Okay, perfect. So, next step would be management with HRT. Roughly 10% of women will require some form of HRT to treat their menopause. And there is currently NICE is trying to increase the number, as they found that women were previously being untreated due to worries about increased cancer association with use of HRT, um, which is true for endometrial cancer. Uh, but what we can do is that women with endometrial cancer can only occur in women who have uterus, right? It cannot occur in women who do not have a uterus. So anyone who has a uterus, we should not give them only estrogen. They should have a combined HRT with progesterone, because progesterone will keep the endometrium at bay rather than just like crazy proliferation of endometrial tissue under the effect of estrogen. So combined HRT is given for patients who have a uterus. So when we are giving the HRT, we need to see if a patient has a uterus or not first. Um, and then, yeah, so uh, before starting HRT, we need to discuss a couple of things with patients that uh, there are some risks associated. So before we give them HRT, we should tell them that the symptoms typically would last from 2 to 5 years. So if they want to go with the lifestyle modifications and just non-hormonal treatments and try and reduce the amount of usage of hormones, that is totally up to them. And but that is something that I advise, to be honest. Um, so in regards to treatment with HRT, um, we need to let them know about the risks associated. So there can be a slight increase in stroke with use of HRT, coronary heart disease. Breast cancer is also associated with use of HRT, and ovarian cancer is also studies have shown that the number has increased with the use of HRT. So once all of these are mentioned, many people would back out from using HRT. Just a second, sorry. So, yeah. So as I said, that whenever we mention these risks, women tend to avoid HRT and only ask for it if they've totally, they've used all the other things and they're totally unable to bear with the symptoms, or have tried all the modifications and everything and nothing is working and they still can't cope. So yeah. Um, if someone wants the HRT, as we've already discussed, that we will see if they have the uterus or not. If they have a uterus, then we will have to offer them a combined HRT. And if they don't, then only estrogens can be given. There are several, so that's exactly what we've just discussed. Yeah, and in this regard, some patients might be using a Mirena coil for some other reason, anyways, like for heavy bleeding or for contraception purposes. So, if someone already has a Mirena coil and starts to have these symptoms and wants to have hormone replacement therapy, then we can continue to use that Mirena as the progesterone side of the supplements, whereas we can only give them estrogen in addition to that. That can be oral or transdermal. Then we need to see if the patient has had um, period for 1 year within the last 1 year or not. If they had a period, then it is better to give them sequential regime. If they didn't have a period, then it is better for them to have the a continuous one. I will talk about these regimes sorry, in detail. So, um, yeah, sequential regime means that they will be given a hormone replacement therapy for 28 days cycle. They will be given estrogen daily, but the progesterone will only be taken for 10 to 12 days of your cycle. And as soon as you stop the progesterone, they will have a withdrawal bleed, right? So this is the sequential HRT. It is generally better for people who have not had who have had a period in the last 1 year. If a person does not have a period for the last 1 year, then it is better to give them combined, a continuous one. And as the name states, it means that they have just estrogen and progesterone daily without a break. So, um, yeah, in regards to having estrogen orally, it is associated with a risk of increased risk of venous thromboembolism or cardiovascular disease. So anyone who has risk factors for VTE or CVD, we would advise them to go for transdermal patch of estrogen rather than oral. If no, then they can choose. It's their discretion. Okay, so consists of estrogen. So just going through everything, I think I've already talked about this, but we'll just read through. So HRT generally consists of estrogen compound, which replaces the diminished level of that occurs in the perimenopausal period. This is normally combined with progesterone if the woman has uterus to reduce the risk of endometrial cancer. Choice of hormones. Now, as I said, there are two hormones, progesterone and estrogen. Estrogens natural estrogens are better, whereas in regards to progesterone, synthetic progesterones are better. We also have Mirena, the intrauterine system, um, and then there's a new one. This is like comparatively a new one, tibolone. So this is a synthetic compound, and it has estrogenic, progesterogenic, and androgenic activity. So androgenic activity is an addition in this one, but studies have shown that it's not as good for the vasomotor symptoms as the other combined HRT. Moving on. So this is just the same that I've already discussed. Sequential combined HRT is taken in a 28-day cycle. This means that you take estrogen every day, but you will take it with progesterone only for 10 to 14 days of your cycle. You repeat the cycle without a break. You will usually have a withdrawal bleed at the end of each course of progesterone. These are the few brands that offer the sequential combined HRT. And then for continuous combined HRT, it is recommended if you're postmenopausal. If you're postmenopausal and you haven't had a period for 1 year. So whatever we've discussed previously. And it can be taken in pills, patches, gels, sprays, intrauterine system, vaginal estrogen. These are the different types that it comes in. We've discussed tibolone as well. It's a prescribed medicine similar to combined HRT, but it also has a testosteronic effect. You take one tablet a day. It can help relieve symptoms such as hot flashes and low mood, although some studies have suggested that it is not as effective as combined HRT, suitable in women who are 1 year postmenopausal. So HRT can be taken orally or transdermal. Transdermal is preferred in women who have risk of VTE, and rates of VTE do not appear to rise with transdermal preparation. So we've discussed all of this. So I'm just going through. Now, discussing about the adverse effects. So because estrogen deals with hydration, like maintaining hydration, it does tend to retain fluid. So whenever estrogen is given, it will cause a little bit of fluid retention and weight gain. It also affects on the breast, so causes breast tenderness. We discussed that there's an increased risk of breast cancer with the use of estrogen and progesterone, so the combined one. So it increases by the addition of progesterone, giving progesterone. Um, and there's a study that shows that there was a relative risk of 1.26 at 5 years of developing breast cancer. So it's not a massive increase. It's only a little bit relative increase. And the risk also relates to the duration of use. So if you stop the HRT, you will notice that by 5 years, the chances of the woman having breast cancer are as equal to someone who's never had HRT. And in regards to endometrial cancer, we've already discussed that estrogen is the one that causes the endometrial cancer if given unopposed. So it should never be given unopposed. So basically, this is reduced by the addition of progesterone, but it's not completely eliminated, so it can still develop. Increased risk of venous thromboembolism. It is also increased by the addition of progesterone. We've discussed that transdermal HRT does not appear to increase the risk of this. So anyone who is at high risk of VTE should be given transdermal preparations and also be referred to hematology before starting any treatments. There's also a slight increase in the risk of stroke and ischemic heart disease, but that is only if taken for more than 10 years.